treatment as a rule looks like some form of nutritional adjustment, and I really let patients decide, because I have patients who tell me, here's my deal breakers, and change isn't something that you flip on overnight. So I don't hand people a diet and ask them to get comfortable. We make small pointed changes that usually come from patients. I'm a big fan, for example, of food diarizing or tracking. There's a lot of science to support that when you track your food, even on a sporadic basis, you can see the nutrients you're taking in and make adjustments. And it offers sort of mindfulness when it comes to eating, and really gives you some guidance about where you can make some changes. I think that medications have a huge place when it comes to modern day obesity medicine. And in Canada, we have 3 medications that are available for use. In the States, they have 6. I'm hopeful that over the next few years, we'll see more of a push towards appropriate, what we would call pharmacotherapeutic options or medication options for patients. The biggest barrier with medications in Canada is cost, which quite honestly is criminal in a socialized healthcare system where the visits I provide are free, but the medications I prescribe are not, unless a patient goes into hospital, and that doesn't make sense. And we're the only socialized healthcare system in the world that doesn't actually have a socialized drug plan, which really impedes the quality of care we're able to provide. And then there's bariatric surgery, which is an option for patients as well, and that's a surgical approach. So when we think about any disease, we think about behaviors, we think about medications, and we think about surgery. And the same thing applies to obesity. We can alter some of those physiological mismatches or those hormonal challenges that exist in obesity by either prescribing medications or recommending surgeries, or a combination of both.